Quddus. He is Samaritan Board in Public Critical Care. He has worked as a professor at Memorial University, Canada. He is currently working in Shifa International Hospital. Sir, please come for your presentation.
Assalamualaikum. So, as my dear colleague pointed out in the previous very interesting talk about that, one of the things that over the years, what asthma phenotype that you're dealing with. So, and because as we go and we have a better understanding of the molecular pathways that actually overlie the inflammatory cascade that occurs with asthma, if we can identify exactly which inflammatory pathway is responsible for the severe asthma that we're dealing with, then we can have actually targeted therapy, we can have more personalized therapy to treat those patients in a much better way. And we can do much greater service if we can get them off a lot of the steroids that they're taking, and they're getting a lot of side effects from the steroid use. So if we have a more personalized, we can identify exactly what phenotype they are, then we can identify and we can target the specific molecules that are responsible and for the asthma exacerbations and the asthma attacks that they're having. So one of the important things for all of us to realize is that there is a very big difference between one asthma and another asthma. So all asthma is not the same, right? Same here. All the political parties in Pakistan are not the same. So one asthma is very different from another asthma, right? So we have the asthma typing from the type 2, which is the high, or the TH2 or the TH2 low, and we have to realize that one of the inflammatory markers that are responsible. So once we have that phenotypic origin identified, whether this is basically from vesically-induced asthma, which is a neutrophilic asthma, which is basically an eosinophilic asthma, which is for an IgE level that we're dealing with, right, or it's virus-induced asthma, or an asthma overlap syndrome that can occur with severe COPD patients. So if we can identify exactly what phenotype it is, then we are much better placed in coming up with a cocktail of therapy that will actually help them the most. So this looks very complicated, but it's actually a pretty straightforward picture which shows you basically outline of how the asthma inflammatory cascade works. Now, one of the things that we have been taught from the very beginning is that we have to start thinking of asthma as an inflammatory disease process. We cannot treat it as any other thing but actually an inflammatory cascade that is present. Now, once the allergen comes, the first thing that they come in contact with is the dendritic cells, and they are basically the antigen presenting cells, and they present it to the T cells which are present. And then there's a whole cascade of reaction, and we have different interleukins that are produced. You have the interleukin 4 and interleukin 5, which are the most of the important targets that we use for the biological therapies. We have the IgE that we target with Xolair, or which is the oldest biological that we have. We have interleukin 9, which is responsible for the mast cell deterioration. We have the interleukin 4 and interleukin 13, also important topics which actually lead to the B cell activation, and that cascade which is shown in the green is basically the allergic eosinophilic pathway. Now, the problem that we have is that we have a lot of good drugs for these allergic eosinophilic airway inflammation, and most of the biologicals that we have are only approved for patients who have actually documented eosinophilia, and we cannot use them in patients who are not eosinophilic. We have very few medications available for non-eosinophilic asthma, and they actually are the ones that tend to do the worst. They are the ones that we actually label as steroid resistant, that they don't respond very well to the steroid therapy. They are the ones that are going to have the severe exacerbations, and they are the ones that are going to come to you again and again because of recurrent exacerbations and requiring high dose of oral steroids. Now we are coming up with new molecules that are actually attacking the interleukin 33 and the TSLP molecule. Now, TSLP is a very strange inflammatory mediator. It's not generated by your typical inflammatory cells. It is actually generated by the epithelial cells. And by targeting the TSLP, which occurs much higher in the inflammatory cascade as compared to the more specific interleukins, which are much lower down in the inflammatory cascade. So, TSLP, if we target it at much higher levels, then we can actually control it. The interleukin 33 is also available, but it's still not FDA approved. So it is being used in the European market, but it's not FDA approved. So it's not being used in the US market. But interleukin 33, which is again much higher up on the inflammatory cascade, is also available. So we have all of these inflammatory mediators, and we can target them and actually stop inflammation from occurring. One of the things that you all must realize that is biologicals are only meant for severe uncontrolled asthma. So these are the patients who have had multiple exacerbations, and we actually classify multiple exacerbations having at least 3 exacerbations in a year. These are the people who are going to have uncontrolled asthma despite optimal inhaled bronchodilator therapy. So they are on high dose of inhaled corticosteroid along with LABA, and despite the high dose inhaled corticosteroid LABA therapy, they are still uncontrolled. So they are going to have high eosinophils, they are going to have high fractional excretion of nitrous oxide levels. So these are still going to be uncontrolled, and only those are the patients we actually refer for biological therapies. Unfortunately, we don't have the biological therapies in Pakistan presently. Number one, cost obviously is they're extremely expensive. And the secondly is that you actually need a dedicated center where you can monitor these patients and where you can have a dedicated asthma clinic with a multidisciplinary approach where you can have the respirologist and you can have the ENT specialist, and you can have an asthma nurse and an educator and a respiratory therapist all working under one roof and only taking care of severe uncontrolled asthma patients. So we needed that kind of a setup along with the funding to actually be able to pay for these medications because they're impossible to pay by self-pay. All of these cost more than $30,000-$40,000 a month for a single molecule, so they're extremely expensive. So unless government funding is available, then these molecules are not going to be utilized in common practice. So they are only being utilized mainly in places where you have a good insurance, where you have healthcare funded by the government itself. Basically, these biologicals are extremely complex monoclonal antibodies. They are large proteins which, depending on where they originate from, we actually name them according to them. So if you have a murine model, which is basically not human, it's called an OMAP, while if you have a humanized, completely fully humanized, it's a UMAP. So depending on the name, you can actually tell that where the origin of that molecule is. Now, as we go up, as we go down the cascade and we become more and more fully humanized monoclonal antibodies, their potential for immunogenicity actually decreases. So they become much more tolerable, they're much easier for the patients. The biggest problem that we had with the Xolair, which is the first molecule that we have been using for now more than a decade, and we have the most experience with, and now it's getting out of favor, and most people don't like it anymore. But the biggest problem that it had was that we had a very scattered patient who would come up with a severe anaphylactic reaction. And these anaphylactic reactions could happen anywhere along the time. So it doesn't have to be the first dose effect. So it could have happened that these patients who have been on Xolair for more than a year, and now they all of a sudden develop a severe sudden anaphylactic reaction requiring intubations and ICU stay and all those things. So these patients had to be given these antibodies in a hospital controlled setting. But now, as we have better and better fully humanized monoclonal antibodies, then the advantage is that they're not as that immunogenic, so they can be administered at home, so they're much safer to use. So we have much easier time actually controlling them. So the main pathway, as we talked about, are the eosinophilic pathways. The eosinophils that actually, the eosinophilic asthma pathway that we talked about. So basically it is the IgE, interleukin 5 and 4, right, and interleukin 13. So they are the main pathways. So most of the medications that we have are basically targeting these eosinophilic asthma, which is your atopic patients, lot of hay fever symptoms, lot of upper airway symptoms, loss of post-nasal drip, very seasonal patients having exacerbation during the pollen season, high eosinophil counts in their blood, high fractional excretion of nitrous oxide. So these are the patients that we actually treat well. The non-type 2 or inflammatory pathways, we don't have much available so far. We have a couple of drugs in the pipeline. They're getting FDA approval as we speak, and hopefully in the next couple of years we may see them in the market being utilized on a clinical practice itself. So the main drugs that we have, the main drugs that we have basically are the mepolizumab and the resizumab, which are the basically targeting the interleukin-5, and these are the ones that basically are given only in patients who have eosinophilic asthma. And these are the one of the must criteria that we have is that they need to have an eosinophil count of greater than 300 before we can prescribe them. So you have to document eosinophilia before you can give them any of these medications. The omalizumab, Risolea, is basically an IgE, and you utilize them for people who have especially high IgE levels. IgE levels ranging between 40 to 700. Once you have people who have a very high IgE level, those are your ABPA patients, then these drugs cannot be utilized. Although we have used them in the past, especially omalizumab for ABPA patients as well, but first the dosing is dependent on the Ig level, so you tend to use a very high dose of this medication if you have somebody with an Ig level in excess of 1,000. And secondly, these patients, they actually develop even higher levels of IgE once you start to treat them. So it becomes very difficult for us to actually moderate the dose of these patients. So we have tended not to use them on patients who Ig levels are greater than 700. And as lastly said, the last TSLP, the inhibitor, that is the one that we have, the TSLP inhibitor which we have available, and the advantage for that is that it is blocking the cascade right at the level. So these are the medications that are all FDA approved right now for the management of severe asthma. So we utilize them in patients who have severe uncontrolled asthma despite maximum inhaled bronchodilator therapy. And one of the big advantages that we get to using these medications is that we can actually not only spare them the oral steroids, we can actually cut down on the dose. There's still a lot of unanswered questions that we have with the use of these drugs. We have some of these patients who have been on this medication for more than a decade now. And despite them having been on these medications, we still don't know how long we need to keep them, when to take them off these medications. And when we take them off these medications, then they tend to relapse pretty badly. They tend to relapse with very severe asthmatic symptoms. So they promptly go back on another agent or one of the similar agents again. So we still don't know exactly how long these patients need to be treated and what are the long-term side effects we are going to get by treating these patients for years and years of these biological agents. Most of these agents are very, very safe. The biggest reaction that we get is a scattered inflammatory reaction that we get because of the use of these monoclonal antibodies. But other than that, they are very well tolerated medications. But we still don't know what the long-term side effects of these are we going to get. So the medication that we have, as we said, the omalizumab is the IgE inhibitors, and that is the one that has been the oldest around. It's the oldest kid of the block, and the first one that became available. So we have a lot of experience in using that. We tend to use it less now, and it's all given as a sub-Q injection every 2 to 4 weeks. The Syncoer and the Nucala, that is basically IL-5 inhibitors. Basically, they are also given, and they are also very well tolerated. But for all of these, they have IL-5 and IL-4 inhibitors. You need to have a high documented high eosinophil count. So once you have somebody who has a non-eosinophilic asthma, then you cannot use those drugs. Then you're either left with the interleukin-4 receptor inhibitor or the IgE blocker for the use in these patients.
Sir, can we cut down the talk as we are running short of time?
That's fine. So I'm not going to go into each one in detail. So if you have any questions, we can talk.
Thank you very much. Do you have any questions?